Hello and welcome back to my channel. Today we will be continuing our discussion of valvular heart diseases, and today we will be concentrating on mitral valve regurgitation. In mitral valve regurgitation, we will be focusing on its causes, history and presentation, examination findings, treatment, and at the end of the lecture we will be solving an exam question. As I've mentioned before, I will be teaching you from First Aid Step 2 CK book along with using other resources including Toronto notes and up to date. Let's begin our discussion of mitral valve regurgitation. Mitral valve regurgitation is a type of heart valve disease in which the valve between the left heart chambers, that is the left atria and the left ventricle, doesn't completely close. So there's a gap between the cusps of the mitral valve. This will allow blood to flow in the backward direction instead of moving in the forward direction, in turn making the valve leaky. This is the most common type of valvular heart disease. If this leakage is very severe, enough blood will not be able to pump to the rest of the body. In return, this will cause you to feel tired and short of breath because a lot of blood will go back into the lungs. The cusps of a normal mitral valve are supposed to be fused together like so during systole. The cusps of a regurgitant valve, however, have a gap between them during systole. This will cause blood to move backward instead of moving forward into the aorta. Let's take out our Step 2 CK book and study from there today's topic. The pathophysiology behind mitral valve regurgitation is as follows. Mitral valve is a floppy valve, which is a leaky valve. This will cause backflow of blood to the left atria instead of moving forward to the aorta during systole. In turn, this backflow of blood will cause blood to go back into the lungs, resulting in pulmonary edema. This will result in congestive heart failure, that is cor pulmonale, which is right-sided heart failure. This is all due to back pressure. So, what are the causes of mitral valve regurgitation? Usually, this happens as a result of rheumatic fever. Rheumatic fever, if left untreated, will cause rheumatic heart disease. The pathophysiology of that is your body will start to form antibodies against group A streptococcus, that is Streptococcus pyogenes, which causes rheumatic fever. Those antibodies will start attacking your mitral and aortic valve because of antigenic similarities between the Streptococcus pyogenes and your valves. In turn, the early lesions will cause mitral regurgitation and the late lesions will cause mitral stenosis. Other than that, another reason could be secondary to myocardial infarction, which can result in the rupture or degeneration of the papillary muscle or chorda tendineae, resulting in valve dysfunction. Anything that causes left ventricular dilatation stretches the mitral valve open. Examples of things that causes left ventricular dilatation can be remodeling post-MI, dilated cardiomyopathy, which can be ischemic or non-ischemic. Some other causes could be Marfan syndrome, which is a congenital disease resulting in floppy valves, calcification of the valves with age, and mitral valve prolapse. So basically in causes we have rheumatic fever, rupture of the chorda tendineae, papillary muscles, calcification of the valves with age, Marfan syndrome, and mitral valve prolapse. How will the patient present to you? The patient will present to you with dyspnea, which means shortness of breath, orthopnea, which means getting breathless while lying down, paroxysmal nocturnal dyspnea, which happens during sleep, and fatigue. The orthopnea, which is getting dyspneic while you lie down, it gets better with sitting. We could also divide the symptoms in acute and chronic. In acute setting, for example during papillary muscle rupture, you will have pulmonary edema and congestive heart failure. This is a medical emergency and you need a more aggressive approach to dealing with this. The signs and symptoms of this can include fatigue, diaphoresis, which is sweating, palpitations, dyspnea on exertion, and lower extremity edema. The chronic causes can be dilated left ventricle due to chronic coronary artery disease, that is dilated ischemic cardiomyopathy, and this can result in fatigue, shortness of breath, and pulmonary edema. What are some physical examination findings of mitral regurgitation? You will find a hollow systolic or pansystolic murmur, which means the murmur will be continuous during entire systole and it will be a flat continuous murmur. This murmur is best heard at the fifth intercostal space in the midclavicular line and it will radiate to the axilla. Echocardiography will demonstrate regurgitant flow. On echo, it will look something like this. If there is mild regurgitation, you will see a little bit of blood regurgitating. If the regurgitation is moderate, you will see a little more blood regurgitating to the left atria during systole, and if the regurgitation is severe, you will see a lot of blood regurgitating to the left atria from the left ventricle during systole. Angiography can assess the severity of the disease. So if we want to know how severe the disease is, we need to do angiography. Another thing we can do is ECG. ECG will show signs of left atrial enlargement and signs of atrial fibrillation. Let me show you how they will look. So on ECG, if you look at the lead 2, you will find P mitral, which means notching of the P wave. You will also find signs of atrial fibrillation, which will have absent P wave and fibrillation instead of P wave, and irregularly irregular heart rhythm, which is shown by the distance between these peaks. These are irregularly irregular. The S1, which shows the closure of mitral and tricuspid valve, will also be a little diminished because the mitral valve will not close properly. One more thing I want to discuss before we move on to the treatment of mitral regurgitation is this entire graph, which they can ask you about in your exams. So this is a graph between the left ventricle and the left atria. Now, the atrial pressure during systole is supposed to be 4 to 12. Basically, it's supposed to be something like this. But if you look at here, the atrial pressure during systole shoots up, and it shows that because of regurgitant blood, there is increased pressure in the left atria during systole. And that is not normal. The atrial pressure during systole is supposed to be between 4 to 12 mmHg and not 70 mmHg. That is a lot of pressure building up in the left atria, and this will consequently result in left atrial hypertrophy and in turn back pressure in the lungs and in turn in the right side of the heart, which will result in right-sided heart failure or cor pulmonale. So if you get a pressure curve between the left ventricle and the left atria, and the pressure of the left atria is shooting up, know that this is a curve of mitral regurgitation. So lastly, let's talk about the treatment options that we can use in mitral valve regurgitation. So we start with ACE inhibitors, which includes captopril, enalapril, all the prils. And we can also give angiotensin receptor blockers, for example, losartan, valsartan, etc. What this will do is this is going to vasodilate and decrease the rate of progression. We also know that anytime there is left atrial enlargement, it can result in atrial fibrillation. So we need to give antiarrhythmics for that so that we can make sure that there's no clot formation and no clot dislodgement. If it causes congestive heart failure, we need to give digoxin and diuretics as well. If we opt for valve repair or replacement, the repair being valvuloplasty, annuloplasty, intra-aortic balloon counterpulsation procedure, or the replacement being a mechanical valve or bioprosthetic valve being replaced, in those cases, we need to make sure that we do pre-op diuretics to decrease the peripheral and lung edema prior to surgery. And we use a mechanical valve in younger people and a bioprosthetic valve in older people. And one more thing you need to remember is that in mitral regurgitation and aortic regurgitation, we do not wait for them to become symptomatic. Atrial regurgitation and mitral regurgitation can be dangerous conditions, and we do not need to wait for symptoms to develop. Instead, if we do find out incidentally that they have these problems, we need to go right away into the treatment. Now that we have discussed mitral regurgitation and all of its pathophysiology and causes and treatment options and all of that, now it is time for a question. So a 53-year-old man comes to the ER with squeezing chest pain that started 2 hours ago. So a 53-year-old man, and if he has come to the ER, that means that it is an emergency condition. He has not presented to the clinic. This is some acute emergency, okay? He is coming with squeezing chest pain that started 2 hours ago. He has severe shortness of breath that is worse when lying down. So if you remember, this is because of backflow. He has never had pain like this before, okay? So this is his first time. He has no significant past medical history and takes no medications, so he's a healthy man. A routine health maintenance visit 2 weeks ago was normal. Blood pressure is 112/60, pulse is 110 per minute and regular. So this means that his blood pressure is dropping and his pulse is exceeding, so there is some sort of hypovolemia. Chest auscultation reveals grade 3 and 4 hollow systolic murmur at the cardiac apex and bibasilar crackles in the lungs. So we do know that hollow systolic murmur happens in mitral valve regurgitation, and you will hear it best at the fifth intercostal space in the midclavicular line, and it will radiate to the axilla. So it is heard at the cardiac apex, which is around the fifth intercostal space in the midclavicular line, and you're also hearing bibasilar crackles in the lungs, which means that there's some sort of backflow. Okay, so now that we have established that he has some sort of mitral regurgitation problem, so let's move on and see what the ECG has to say. The ECG shows ST segment elevation in lead 2, 3, and AVF. So ST segment elevations usually points towards STEMI, which is ST segment elevation myocardial infarction. Which of the following is most likely to be significantly increased in this patient? So now that we have developed that this patient has mitral regurgitation, and because of mitral regurgitation, he is now going into STEMI, we can safely say that this is an acute condition and just something has happened that has caused the patient to have mitral regurgitation acutely. So in acute conditions, what can happen? So if you remember, we had discussed that in acute conditions, the papillary muscles can rupture, which is a medical emergency, and it causes pulmonary edema and congestive heart failure, and the signs can be fatigue, diaphoresis, palpitations, dyspnea on exertion, and lower extremity edema. So now they want to know which of the following is most likely to be significantly increased in this patient. So the first thing they're asking is left atrial compliance. Left atrial compliance would have increased if this was a chronic setting, but this is an acute setting, so left atrial compliance cannot increase this fast. Left atrial size would also have increased if this was a chronic setting, but since this is not a chronic setting and this has all happened all of a sudden, this is not correct either. Left ventricular compliance. This is also not correct because this would also increase in a chronic setting. Then we have a right ventricular preload. Right ventricular preload has nothing to do with what goes on in the left side of the heart. The preload is based upon how much blood comes back into the heart from the rest of the body. So this is also inaccurate. What's left is left ventricular filling pressure. So why would left ventricular filling pressure be increased? So this is the heart, right? So let's suppose this is the heart, and because there is mitral valve regurgitation, a lot of blood is going back during systole into the left atrium, and this will result in a lot of blood pooling in the left atrium during diastole. And a lot of blood will come back during diastole into the ventricles, and that will increase left ventricular filling pressure. And because this left ventricle filling pressure has increased, in return, again during systole, a lot of blood will go back into the atria and a lot of blood will go back into the lungs, resulting in symptoms like dyspnea, which is shortness of breath, and it will become worse on lying down. So that's why this answer seems the most correct, and 35% of people have chosen this as well. So left ventricular filling pressure will be increased when it is a case of acute mitral regurgitation. So you'll get questions like this, and if your concept is clear, you'll be able to answer such questions. A lot of people, if you look at this, have answered a left atrial size, which also increases, but it will only increase in a chronic setting and not in an acute setting. So have your concepts clear like this, and only then will you be able to have a correct answer. This sums up our discussion of mitral valve regurgitation, and I will meet you in the next video with some more exciting topics, and I hope that this helped you, and if it did, please share this video with your colleagues or other medical students who might also avail benefit from this content. I will see you in the next video. Till then, take care of yourself and subscribe to this channel. Bye!